Hi, good evening, everyone. Welcome back to another session of webinar. And this is on Wednesday today. This week we had 2 webinars, and we welcome back Dr. Felix Yap again for a very interactive session. I hope you will interact. And of course, if you don't know me, I'm Dr. Betty Tay. I'm the founder of Beating Hearts, and we have been quite active again after we started this year. So without further ado, we call Dr. Felix.
Can see the slide, right?
Can.
Okay. All right. First case, I've just seen this patient on Monday. He presented with this skin lesion. He told me that this skin lesion has been there for the last a week or so on the right side of the cheek, increasing in size over a period of 1 week. From a very small lesion just pop up to become a big lesion like this for 1 week. What do you think this patient has?
Is it itchy?
Not itchy.
SCC.
Not painful. Just a lesion like this.
Anyone? Come. Let's start. Basal cell carcinoma, Kuan Ming.
SCC.
SCC. Okay. All right. Anything else?
Melanoma. Well, this time a lot of people replying quite fast, huh?
SCC, BCC, melanoma. Anything else that you think is possible?
Kuan Ming. Kuan Ming, you make 2 diagnoses. How can? Stick to 1 diagnosis. Which one do you think?
Can.
Okay.
Differential. Wow, very good.
Differential. Okay.
Anything else? BCC, SCC, melanoma, keratoacantoma.
Okay.
I think basically that's it lah. Okay.
Okay.
Very, very fast lesion. Most likely is keratoacantoma. But this patient is old. He is almost 80 years old. So for a keratoacantoma, most likely is keratoacantoma, but there is a variant of SCC that looks like keratoacantoma. So it's keratoacantoma type SCC, squamous cell carcinoma. So I've just excised this lesion. So I'm awaiting the biopsy result of this lesion. This lesion is quite big. Actually, it's around 3 mm by around 2.5 3 cm by around 2.5 cm. So it's quite a big lesion. But because
over 2 weeks.
Sorry?
Over 2 weeks.
Over 1 or 2 weeks, it grows at
Very
least.
fast,
So when the lesion grows very, very fast, so the diagnosis most likely is keratoacantoma. But whatever it is, we just need to take this out because it might be SCC. There might be an underlying SCC.
Okay, when you first explain to me what is the keratoacantoma.
Keratoacantoma is a misnomer lah. Actually, is a type of abnormality. Is a excessive production of squamous cell, keratin cell, over a very fast period of time on the skin lah. So keratoacantoma is non-cancerous. It's non-cancerous. It's benign. It's benign. So keratoacantoma sometimes can mimic squamous cell carcinoma. So whenever you see a keratoacantoma, you need to biopsy. If you don't know how to excise, then you need a biopsy. Like if you know how to do a proper excision, then probably proper excision would be the method of treatment of choice.
Okay, can I ask another question is, when you have a lesion like this and you think it's keratoacantoma, but it could be basal cell carcinoma, you said, right?
SCC,
Squamous
squamous cell carcinoma.
So when you excise, right, do you excise further
White
away.
excision, white excision.
Oh, you do
Yeah,
white.
we do a local white excision. We do a local white excision. But keratoacanthoma, actually, if you don't do anything, it's self-resolving, like it resolve by itself.
Oh, I see.
It's self-resolving. So sometimes we don't want to let it self-resolve because we don't know whether it's SCC or not. So most people will biopsy. If you biopsy and then it turns out to be SCC, then you need to recut again. So the patient need to come for 2 times for surgery. So sometimes I'll just do excision straight away. And in private, every single thing you do is money lah. So old patients usually they don't have insurance, so we just have to do it 1 time for them. And second thing is that you ask a old patient, elderly patient to come 2-3 times for excision and all, they're probably not very keen to come again. So usually 1 time and then settle it off lor.
Okay, can I ask you, is basal cell carcinoma or squamous cell carcinoma more common, and the prognosis for both of it?
Basal cell carcinoma more common. Basal cell carcinoma is called rodent ulcer. So basal cell carcinoma is usually locally invasive. That's why it's called rodent ulcer. Rodent is rat. So it's like the rat eat the skin, and then it goes to the bottom of the skin. So rodent basal cell carcinoma is so much more common. Basal cell carcinoma is not usually doesn't metastasize. The amount of metastasis is very minimal, and it's just require a wide local excision. Squamous cell carcinoma requires a wide local excision, and on top of that, if there is lymphatics or there is hematogenous spread, then you have to do a CT scan or a PET scan to look for any other foci of the malignancy.
Okay, so we have that. Wow, we have a lot of people coming in very fast. We can go on.
Okay, so 1 is done. I think probably quite easy lah, straightforward lah. Second case would be
For you lah.
this patient. This young lady comes to me with a mole like this. And then I do a dermatoscopy. The dermatoscopy turns out to be like this. Do you think I need to excise, or do you think I don't need to excise?
Okay, anyone?
Need to
And
exercise.
what excise? What do you think is the diagnosis?
Melanoma.
Okay, melanoma. Anything else?
Okay, sorry, because I get a bit surprised there is a voice coming out. Yeah. Okay, I think it's also acceptable. You can unmute yourself and tell us your diagnosis. But I'm just not used to it. Okay, go on. So you think it's melanoma. Okay, anyone else with any other differential?
Quite small. Is less than 1 cm. It's less. I think it's 0.6 mm, 0.6 cm, 6 mm or so lah. The skin lesion, a small skin lesion.
Never come anymore lah. Sad lah.
Yep. This plastic nevus, okay. Anything else? Melanoma, this plastic nevus.
Let me see where can't see the. Okay,
Okay.
pigmented cereboric.
Seborrheic keratosis. When you look at this lesion, you see there's a dark lesion, and then when you see the dark lesion, there will be spikes. Can you see spikes? It's like spikes going out from the lesion. It's a spiky, it's like durian.
Is this
More more don't have durian configuration. More a normal melanocytic nevus, either it is a compound nevus or a normal nevus. Usually is no spikes that we can see. It's just purely a homogeneous color. Sometimes they have slightly different color on the edges, a slightly darker color on the in the center, but it's not it's usually not spiky. So when you see spikes, then most of us would be a bit more worried, because like what Guan Ling said, dysplastic nevus, we are worried about dysplastic nevus. We are worried about BCC when we look at spiky lesions. So when you look at spike like this on the mole, most likely the diagnosis is Spitz nevus. There's a type of nevus called Spitz nevus. Spitz nevus again divided into two. The typical Spitz nevus, it looks like this. Then there is another one that is atypical Spitz nevus. I cannot differentiate between a typical Spitz nevus or a typical Spitz nevus. So in this patient, I excise the lesion. I send it for biopsy, and biopsy turns out to be just a normal Spitz nevus. Spitz nevus can sometimes be confused with melanoma. So we always need to excise anything that looks like this to just make sure that we are on the safe side and it doesn't turn out to be malignant melanoma. The good thing is this patient is a young patient. She's 19, 20 years old. So most likely we are not dealing with melanoma. No family history of melanoma. I think it's at the time I think it's Spitz nevus. It's just to biopsy to confirm that it's Spitz nevus only lah.
Okay, how do you spell PITS? P-I-T-S?
SPITZ.
Oh, Spitz. Oh, okay. And then the other thing is, when you say melanoma and then there's no family history, is it common to have family history?
Most of the time when you look at melanoma patients, there is usually some family history lah. Of course, melanoma usually runs in the family lah. So if your parents have melanoma or your family members have melanoma, you have to be extra careful because the patient tends to have melanoma.
Okay. Okay, can we go on?
Okay, all right.
Good.
So next, this patient initially memang got a mole on the neck lah. Suddenly they come to me saying that the mole become white. What do you think is the diagnosis? This is a mole lah. The center here, this is a mole. Suddenly become white. So what to do?
I think, oh, where is that?
Melanoma as well.
Melanoma. Anything else?
What is that thing that Michael Jackson claimed he has?
Vitiligo.
Oh, vitiligo.
Okay. Anything else?
Anything else? Anyone? Oh my God. Hello, nevus. Hello, nevus. You're saying hello to the nevus? Oh, Guan Ming is very
Anything
sure.
else?
Okay,
Anything
anyone
else?
else? Guan Ming, you're doing dermatology, is it? Or MRCP? No one? Come on. PIH,
PIH.
no, Russia. What's PIH?
Post-inflammatory hypopigmentation.
No, Russia also had a good. Okay.
Okay, this is a mole, and the mole actually become white is halo nevus lah. Halo nevus. So actually what happens is that a proportion of our mole, maybe 5 to 10% of our mole, your immune system will destroy the mole, because mole is an abnormal tissue. It's a nevus tissue. So all these tissue are abnormal. So this abnormal tissue sometimes can trigger your immune system to detect this abnormal tissue, and this immune system will detect the abnormal tissue and it will fight. And when it fights, it destroys all the nevus cell. The nevus cells are the black cells, and when you destroy the black cells, there's no more black cells that give you the pigment. The whole thing will become white color. Okay. So these patients with halo nevus sometimes can have associated vitiligo.
Oh, okay. So I'm not wrong.
They can have associated vitiligo. So this type of treatment, sometimes what we do is you can actually treat them like vitiligo lah. Some people actually will cut it out because if let's say you have something, some of the cells attacking your nevus cells, you might think that this is actually not nevus cell. It might be very atypical cells. Then you have to rule out melanoma. You have to rule out some abnormal cells, but it usually tends to be a normal nevus that your immune system just fight against the nevus. Okay, so if we have a mole in our body, probably around 5 to 10% of the mole will disappear over time. Your body will get rid of the mole and it will disappear over time. This is just a abnormal response that give you this white color. Most of the time, the mole will just disappear by itself. Okay? All
Okay.
right. So this patient presents with this lesion on the nose and on below the eyelid, left eye, left eye. So what do you think? What do you think? Okay,
Oh,
Noasia say BCC. Anything else?
oh,
Queenie say BCC.
Queenie is here. Queenie. I
Anything
think
else?
it's that pot thingy. I watched that Pimple Popper and she has this pot. Don't know what pot. Never mind me. Okay, BCC. Anyone else?
Melanoma? SCC? Scar? So I think Noasia and Queenie is right lah. This is BCC lah. When you look at this is this one has a pearly edge. Yeah, pearly edge. The borders are rolled. This is rolled, and then this is ulcerated. So these are two BCCs together. These are two BCCs together. So you need a local white excision for this patient. I'm unable to do this patient, so I refer to our plastic colleague because they need to cut very wide here, and also they need to cut very wide here. So probably they need to do
Yeah.
grafting. So I'm not trained in doing grafting, so I don't know how to do this.
Okay, can I ask you, like BCC,
Yeah.
does it have an area that is more common in our body?
Most likely is the face lah. Most like any sun exposed area lor. Usually is the face. Usually the most common is the face. So I'm not trained in most microsurgery. I'm not trained in doing skin grafting. But if you want this one, you can refer to a most microsurgeon. They can do most microsurgery, and the wound will be much smaller lah compared to you do a wide local excision with grafting. Most micrographic surgery. So what they do is they'll cut small segment of the skin out, and every segment they'll send for frozen section. So there will be a pathologist in the OT. So every small little section the pathologist will read, and the pathologist will confirm that until they reach a certain level, then the pathologist will tell them, okay, this level is complete. There is no more malignant tissue. Then you can stop digging, and then after that there will be a big hole on the area there, If the hole, you can do a Z-plasty, or you can do a direct suturing. You suture back. Most of the time, what they do is they'll extend the wound and do a Z kind of suture to release the tension lah. But if cannot, then probably they have to do a skin grafting lah. Okay, this is SR. So this patient came to me for lesion on the scalp. Lesion on the scalp. You see this lesion on the scalp, he's a very old patient, he's around 80 years old. And then you can see there is some purplish discoloration, red discoloration of the scalp, is soft and firm. What do you think this patient have? It's really an old elderly patient lah. Elderly patient. What do you think he has? SCC. Anything else? Anything else? What else do you think besides SCC? Is it BCC?
One
Is
means
it other
melanoma.
skin lesion?
One means melanoma.
Melanoma, Kwan Ming. Anything else? It's soft, it's soft. It's very soft.
No?
Maybe if those who have done who is doing dermatology or doing training in dermatology, probably they will know lah. A scalp lesion which is soft, which is purplish on the scalp of an elderly man, then probably there are not many diagnoses that you can think of lah. I think probably those who do dermatology training could get it right lah. Anything else? Anybody else who wants to try to get a diagnosis? You can see that biopsy was done here. It's not done by me, it's done by another dermatologist. The patient came to me as a second opinion.
Somebody, Nicholas Chua said melanoma on Facebook.
Right,
Yeah.
right. Blue nevus, hemangioma, Shamil. Okay, Shamil is getting on the right track, hemangioma, but hemangioma usually in children. This is in adult. So this is a blood vessel problem in adult, in elderly. So when you look at elderly, you always think whether it's malignancy or not. It's not venous
Angiosarcoma.
malformation. It's not venous malformation. Venous malformation usually again in children. So this is a condition called angiosarcoma.
Oh my God!
Yes, Queenie was right. Angiosarcoma. So it's a blood vessel tumor. Blood vessel tumor, angiosarcoma. More common in elderly. You can get it in young people. That is more common in elderly and almost always on the scalp. So if you get an angiosarcoma very, very early on, usually one or two on the very, very early stage, refer to the plastic surgeon. They can do a very wide local excision and then they'll refer to our oncology colleague. But in this case, you can see that this area is involved. This is red, this area is involved. Those area of involvement is very big. So it's very difficult for the plastic surgeon to cut the whole scalp off. Yeah. You can see here, until here is all bruising. So this probably has the angiosarcoma has infiltrated the whole scalp. Yeah, the frontal area. So this patient probably needs to go through radiotherapy and some possible chemotherapy lah. So what I did is I refer to the plastic surgeon because if it's possible to do excision, they'll do excision first. That will be the first line of treatment. Then they will refer to the radio oncologist.
Okay, this angio is
Yep, right.
artery, right? Arterial.
Angios, it's just blood vessel lah. It's just blood vessel.
It can be any blood vessel.
I think it's probably the combination venous artery all together. It
Yes.
becomes a sarcoma lah. It's just a blood vessel tumor. you cannot do embolization. No way of doing embolization because the whole area is full of the malignancy. The whole area here. Maybe if you got one, then probably you embolize is okay lah. But the whole area here, so very unlikely you can do anything. The usually is the oncologist will decide what to do lah. All right, next one. This patient on the back, very, very painful, very, very red. I think this is quite easy lah. All of you probably will know lah. Angiosarcoma is a vascular tumor. Yes, you're right. Sebaceous cyst, very good. Anything else? At the back, very, very painful. So you can see that there's a dot in the center. It's swollen. Yeah, I think all get correct lah. Noacia, Queenie, infected sebaceous cyst. So what do? Do you give antibiotic or you cut or you leave it?
Antibiotic.
Antibiotic. Okay. Excise. Anything else? Okay, so what usually I do is I drain lah. I drain. This type is not very red yet. So what I do is I drain. I give I do excision lah. I do a small incision. I'll drain the pus, and if I can pull out the epidermal cyst with the sac, I'll do it at the same setting lah. If I cannot pull out the epidermal cyst, I will drain all out. I'll do something like what we call as IND. And then after that, I'll give antibiotic and I will pack this lesion. And then I'll bring them back to do excision much later on. But this case like this is quite easy for me to do everything. So I will cut, I will take everything out, and then I will stitch back, and the patient will be very happy within 2 weeks. Because after 2 weeks, I'll take off the stitches. Patient will go home very happy. Sometimes if you just give antibiotics, because there is collection of pus, the lesion will burst. Then the infection will go very deep inside. And then we are not able to take out all the epidermal cysts, including the sac. And then once the inflammation settles, then we'll do a very wide excision lah. So usually what I do is I will do a very small incision. I will pull out everything out, and then I will stitch back lah. So much easier for the patient lah. So most of the time, a bit of infection or inflammation or inflamed sebaceous cyst, I'll just excise or I will do operation straight away. Okay, this patient presented to me like this. What do you think? Itchy, very, very itchy. This one very interesting. What do you think? You can see got line like that one.
Allergy to the
Allergy to what?
the sandal. Only one foot.
Only one. Sandal. Anything else? This one beats me. I see also. I don't know what is it. I know it's allergy. What causes the allergy? I was like scratching my head. What, your sandal got like that? He said no. Then you see the sandal come in. Why got thing at the up there one? Beats me. I was like, wow, why like that one?
Okay,
Yeah, you're all right
because
lah. Allergic contact dermatitis.
because
It's just
it's
the
a
thing
woman,
is,
right?
what
Okay,
do you
so
think that caused this?
I think it's the shoes, because you see it's a woman and we wear all sorts of shoes. Sometimes I wear like the gladiators shoes, where there's like one strap, one strap, one strap. Okay.
Too big lah. Too big.
Huh?
This is big, you know.
Yes, but this
Why
one
upstairs don't have lah?
allergic to sports tape.
Ui, this fella very good leh.
It's Dr. Chan. Dr.
Wow,
Chan.
very good leh. The sports tip. This is what she wear.
I see.
This
Oh,
fella
that's
very
what
good.
she wore.
This is what she wear. She's allergic to this. So nowadays you see all these badminton player and all these things this thing
Yes.
can cause allergy because every time we see badminton, see tennis, people strap here, strap there, strap everywhere. and it actually can cause a lot of allergy. This is the first time I see this type of allergy, so that's why I'm so curious. I said, "What is allergy?" Then after that, she showed me a photo of this. This is what she wore.
Oh, well done, Dr. Chan. Okay.
Wow, this one very good, very good, very good. Okay, this is a child. I can't remember her age. Probably a 3 or 4 year old child. Presented like this. Initially, she had a bit of fever, a bit of unwell, no cough, just fever. And then within a day or two, this rash come out. She came to see me at 7 or 8 days after the rash pop out. Seen a pediatrician. Pediatrician treated, not getting better, and then come and see me with this type of rash. What do you think she has?
German measles.
They're not very itchy, not very itchy. Very minimal itch. Um, Initially the mother said a bit irritable. Then after that, the child is okay. But you can see is redness, and there's a small little scaling here. And then you can see crusting a bit, scaling a bit like collarette scale, but crusting. Some area look like what we call you call as iris lesion, like target lesion, but it's not really target. No pus, just crust and collarette scaling. Some of it actually has healed with hyperpigmentation. What do you think it is? Mm. So Queenie said plava. Any other guess or any other differential diagnosis you want to entertain?
Anyone else? Let me see if anyone else?
Catate psoriasis. It's a child, it's very young, very young. I think 3 years old or so. Nowadays, I rarely see children because I'm a adult dermatologist, but I'm trained to see pediatric patient because in Sunway now we have a pediatric dermatologist. So usually children who comes to me is usually when their parents or their brothers and all is under my follow-up, then they'll come and see me lah. Otherwise, usually will be referred to pediatric dermatologist. This happens that the mother is my patient. So pityriasis rosea,
Somebody said pityriasis
impetigo,
versicolor. Col.
pityriasis rosea. Okay. This patient actually, I think your differential is correct lah. The person who has the correct diagnosis is Queenie lah, is plava. Plava is called pityriasis lichenoides et varioliformis acuta. So initially, somebody said looks like chicken pox. So this lesion looks a bit like chicken pox, but it has crusting, and when the crusting actually heals a bit, they give rise to a collarette scaling, is red. It usually presents after a bout of fever or viral infection. So this patient, I gave her erythromycin, and then give her a bit of moisturizer and a mild steroid cream. Everything resolved within 2 weeks. Everything resolved within 2 weeks. So it's a typical picture of a plava. So if lesions go prolonged like 6 weeks, 8 weeks, 3 months, then we have to think about a condition called pityriasis lichenoides chronica. This is the chronic form. So I didn't do a biopsy because the parents refused a biopsy, and I also don't want to do a biopsy in children. I will end up doing a lot of listening to a lot of crying. I don't want to.
The pathology behind this plava.
It's just the immune system. It's like autoimmune. It's triggered by the infection.
Oh, I see. Okay.
All right. So next one, I think this one quite easy. Patients present to me, seen by a few GPs, not better. And then you can see that there is a lesion. This is the popliteal fossa lah. Okay, so above and below the joint is swollen, is crusted, is red, is itchy, is painful. What do you think it is?
Eczema.
Anything is pederos dermatitis. Anything else?
I think it's eczema.
Yep, eczema. Anything else?
Well, your
This
kids,
has been treated for quite some time. It has been treated for around 3 weeks or so. Not better than see me as a fourth person lah.
your cases are getting more and more difficult for me, lah.
Anything
Okay.
else? Pederos dermatitis is caused by beetle lah, rove beetle lah. She didn't give a history of being bitten by anything. She didn't see any insect also.
Yeah, anyone else? Come on.
我是说呀，有点大了哎。
Okay, we need to silence that person.
Then is actually started off as a small little lesion here, and then it gets worse, and then after that spread. Okay, when we look at this kind of lesion, very typical, you can see two round coin-shaped lesion is discoid eczema lah, discoid eczema. But the thing spreads like this. So if the thing spread like this, you have to think whether the redness spread, is it infection, number one, or is it contact dermatitis? So when you ask a question, this patient has simply applied, you have applied multiple type of medication. You have applied the medication from doctors. They have, mother-in-law will ask you to apply this, mother will ask you to apply this. They have applied multiple type of medication. So actually this one, the whole thing is contact dermatitis. So this is discoid, infected discoid eczema. And then after that, they applied so many things, it becomes a contact dermatitis. It contains a contact dermatitis. So this patient have infected eczema plus a component of contact dermatitis. That's why it's not getting better. He was given steroids. She was given short period of steroids. She was given antibiotics. And then after that, things get worse because they have applied so many things. So the treatment, stop everything, just apply simple treatment, give them steroid, give them some oral steroids, oral antibiotic, give them very mild steroid, probably combination of fusidine with betamethasone, or you just use mometasone or betamethasone alone, clear it off, and then the lesion will clear. Usually they will clear off within a week or so. Okay, so when the lesion doesn't clear, think whether it's infection. If you don't think it's infection, think about whether it's contact dermatitis. Get a very proper history of what they apply. Because in Malaysia, people apply whatever thing they can get hold of because things are not getting better. They'll apply Zambak lah, Feng You lah, some Thai oil lah, some Chinese oil lah, whatever lah. Yeah. Sometimes for what you know, they'll apply some toothpaste lah, because the mother-in-law say after put a toothpaste will get better lah. Okay, any question you want to ask about this? This is quite easy lah. So next one, this is a child lah. Incidental finding lah, come to me, mother, talk, and say, hey, you can see my baby, my child or not? My child got this. What do you think? Okay, Euven. Okay, Queenie is saying Euven. Euven is inflammatory, like inflammatory what? Verrucous epidermal
tired
nevus.
already like you.
Inflammatory linear verrucous epidermal nevus. Inflammatory linear verrucous epidermal nevus. Okay, anything else that you can think of? But this is not inflamed lah. This one is basically not itchy, not painful. It's just incidental only lah. Anybody else know what it is? It comes out when she was a baby.
Incontinentia pigmenti.
Incontinential pigmented, yes, there can be a differential diagnosis. Incontinential pigmented, very interesting. You get the Chinese character writing.
Oh, really?
Oh, very nice one. Their skin looks like
Calligraphy.
Chinese character writing there, but not
Calligraphy.
nice for the patient, nice for us to see lah.
Okay, Ray Ong,
Hmm.
nevus. He said nevus. This Ray Ong
Yep.
is very, Ray, are you not a cardiologist? Okay,
So so
blue
this one
nevus.
is not blue nevus. Blue nevus is just blue color and it looks like your mole lah. That is blue nevus. This one you can see is a linear pattern. So Queenie is right, is linear. So this one is actually linear epidermal nevus lah, minus the inflammatory lah. It's just linear epidermal nevus. There's no inflammation there lah. Linear epidermal nevus.
So this
Yeah.
is actually
So
like a mole, you mean?
it's not a mole. Nevus for us, nevus means is like birthmark like that lor. Nevus is called a birthmark lor.
Not
Uh,
mole.
it can be anything. One birthmark can be anything. Mole is if it is a mole that comes out at birth is called melanocytic nevus. If it comes out at birth, it's called congenital melanocytic nevus lor. So if it's acquired one, it's called melanocytic nevus. Acquired melanocytic nevus lor. Nevus sebaceous of Jadasson is uh, yellow in color rather than it's dark in color. Most of the time it's yellow in color because it's sebaceous nevus lah. Sebaceous means it comes from the sebaceous gland. So it's usually studded with sebaceous gland, which is yellow in color. Usually you see sebaceous gland, sebaceous nevus on the scalp, but you can get it on the face as well. But usually not on the thigh or the leg lah. Okay, so this is just incidental finding. You can't do anything much. I have one Japanese patient who have this. The mother is not happy with it, so I do multiple session of laser for the child lah. But the problem is because it's congenital. So how many session of laser you do, you come back. So I usually advise for excision, but they're so big. This type is so big, so excision is usually not possible lah. A small one, then you can probably excise. Or you need to do a very deep laser until it scars. Otherwise, it will keep on recurring. If your laser has not enough depth, then it will always come back.
What is the pathology behind the nevus?
Nevus law, it's just during the formation of the baby, there is overlapping of the cell, and then this overlapping of the cell on the epidermal layer cause two layers go together and then cause the nevus to come out.
I see. Okay.
Okay, so the next one is the last one.
Okay.
So this patient very, very interesting, come to me, a very interesting case. He come to me with this kind of lesion on the thigh lah, on the left thigh. He's Iron Man lah. He's not Iron Man as in the Iron Man that can fight in MCU. It's Iron Man that runs, do bicycle and do swimming lah. So that kind of Iron Man with the thing in the center of the chest. And then after the Iron Man, he told me he got bitten by something in the water. Then after that become like this. He have seen multiple doctors for almost like few months. I can't remember how many months, I think 3 or 4 months or 6 months or something like that. Not better. And then is referred to a colleague to me, and then present like this. Very interesting. What do you think? I know the diagnosis. Now I treated him, everything clear off. But what do you think? What are your thought process when you see this patient? He gave me a history that he's bitten by something, and then is in severe pain. Cannot walk, come in with a wheelchair. Cannot walk, very, very painful. Ectyma gangrenosum, anything else?
Jellyfish thing.
Jellyfish. Jellyfish thing doesn't look like this, jellyfish thing also never go so bad one, no. Impetigo, Yeah lah, impetigo, but the multiple doctor have given him antibiotic macam tak jalan only, and a bit itchy lah, a bit itchy. And then he also put a lot of all this funny stuff also lah. Sporo, yep, interesting. But how to get sporo there also I don't know. He doesn't have a cat. And he don't do gardening. I was initially also I thought it might be Mycobacterium marinum or typical Mycobacterium like abscesses. Treated him initially, but doesn't respond to clarithromycin, doesn't respond to combination of clarithromycin, rifampicin, doxycycline, also doesn't respond. Very interesting. So this one very difficult. It beats me. So I admit him. I did a biopsy. Biopsy turns out to have vasculitis. He has vasculopathy. So there's you have blockage everywhere. You can see that there is a purplish discoloration all here. And I do biopsy, they see the blockage everywhere. Probably the blockage is due to the infection. I waited for the TB culture negative. I sent TB PCR negative. I sent NTM PCR negative. I did fungal culture negative. But the blood, the swab CNS culture turns out to be positive. And for what you know, the swab CNS culture Stenotrophomonas multifila. I've never seen Stenotrophomonas multifila in community. I only see Stenotrophomonas multifila in ICU patient. And this patient has Stenotrophomonas multifila. So first biopsy, first swab CNS, sensitive to meropenem. So actually, I gave him ertapenem, meropenem, imipenem is the same group. I gave him ertapenem. After 1 week, things get a bit better. We cut off all the scab, all the crust. It becomes a deep ulcer. Initially, the ulcer responds a bit to ertapenem. Then after that, doesn't respond. And then the second swab result, resistance to meropenem, ertapenem, and also imipenem, and only sensitive to Bactrim. So I started him on Bactrim. When a dermatologist start on Bactrim, he will have a palpitation every day. So I started Bactrim for him, keep him in the ward for 1 week. Everything is okay. And then I gave him super high dose of Bactrim. And then after 3 months, everything clear off lah. He comes for dressing every 2 days. Now everything is totally clear. I also gave him aspirin, but he cannot tolerate aspirin. So now on Plavix. So for the next 2 weeks, I will keep him on, and then I will stop the medication all in 2 weeks' time because of the vasculopathy. The vasculopathy is usually the blood vessel is usually due to the infection, but I do not want to give any chance because initially I thought it might be this might be due to vasculitis. Because you can get severe vasculitis, and if you get a medium vessel vasculitis, you can get similar presentation like this. So initially, I thought it's just vasculitis. Started on aspirin and also steroids, but then things doesn't work. Then only when I admit him, swab. Because like this, you swab is negative. So we cut off everything and then swab the bottom. That's why we got the Stenotrophomonas multifila. Very, very interesting case. I've never seen this before lah. So
Where did you get it from?
it's just one of the rare cases that we see here lah.
So you don't know where he got this
No, where he got the bacteria, I have no idea.
the
I
other
always
person
thought,
is, sorry, you said that you get worried when you put them on Bactrim. Why is that?
oh, Bactrim always get drug allergy. Bactrim can get Steven Johnson, and toxic epidermal necrolysis patient can die because of that.
I see.
Very scary one. Bactrim is one of the scariest drug to give lah. For me lah, for me. But I think the infectious disease physician will use Bactrim left, right, center lah because of PCP prophylaxis lah, PJP prophylaxis.
Oh, I've never used a Bactrim except when I was waiting for my SPM. I worked in a clinic, which was a long time ago, maybe 30 over years ago, and they used a lot
Bactrim is an
of
old
Bactrim.
drug lah. It's an old
Yeah.
drug, but it's very, very good to use for all these funny infection lah. Even MRSA, community acquired MRSA responds very well to Bactrim lah. It's just I have no guts to give lah. Because I treat Bactrim allergy so much that I see Bactrim also I scared lah.
Oh, just like when I've given one person xyloric, allopurinol, and then he develops such bad reaction. Now every time I give allopurinol, I also get a bit worried. Okay.
Allopurinol is one of the also notorious drug lah. So whenever we start allopurinol, I will start very, very low. I will start off with 100, then after they go 200 and then to 300 lah. But these drugs are the drugs that when dermatologists see this, dermatologists will get very agitated lah. That's it lah. Another drug that I get very agitated, hydrochlorothiazide also.
Oh, hydrochlorothiazide also can get rash, I know, but not very
Yeah,
common.
you get photosensitivity.
I see, okay. I must remember that.
Yeah,
Okay, then.
it's a very common drug. So
Yes,
the
very
more
common.
common the drugs, the more side effect you get lah. That is normal. Even paracetamol we see a lot. Acoxia is one drug that give rise to a lot of fixed drug eruption. Etericoxib. I got one patient very funny one. One day took Acoxia, got fixed drug eruption. And then the friend say, oh, this drug is very good, but it's not written Acoxia, it's written some, because it's a
Oh, I
generic
see, okay.
etericoxib. Go and take and kena again. I'm going to see doctor. The doctor don't know this thing. One time, kena again. Then I said, uncle, you don't take etericoxib.
Oh, my sister also has fixed drug reaction with Celebrex.
Yeah.
Yeah,
So once you have, you cannot take lah. But this type of things, because you ask the patient give you funny name, and then didn't bring the allergy card, didn't bring this, didn't bring that,
yeah.
then sometimes the doctor will just give lah. And
Okay,
the
are there
friend
any
also,
questions? Are there any questions? Let me check Facebook. Yeah. Okay. Very interesting this time. Every time, actually. And thank you for coming in with such a short notice. But I think we will be able to give CPD points to all the doctors. And what beat him in the water? Dr. Me
I have
asked.
no idea. I really have no idea. I really have no idea. I'm just he just told me the history. I really don't know how he got the thing. Maybe I'm just wondering whether he has gone to a clinic and got the infection from the clinic lah. But he said once he has bitten, it's like this lah. Not sure. Yeah.
Okay. Thank you very much, everybody. I'll see you next week. We have another session by Dr. Chong, I think, who was also our Sunway colleague, but has gone to Picasso. And Felix, I see you tomorrow. Thank you very
See
much.
you.
Bye,
Thank
everyone.
you. Bye bye.
Thanks, Felix. You look so tired.
Yeah, very tired. Sorry.